2025 Hepatitis B Community Forum. It is my pleasure to welcome you here today. My name is Shari Cohen. I'm the president of the Hepatitis B Foundation and a professor at the Baruch S. Blumberg Institute. This is our 6th annual Hepatitis B Community Forum. It is hosted by the Hepatitis B Foundation and ICE-HBV. And each year we host this forum in alignment with the International HBV Meeting. And it is a chance for different stakeholder communities to come together and highlight what's happening in hepatitis B treatment, drug development, and elimination, and to hear from people who have lived experience with hepatitis B and hepatitis delta. Each year we try and highlight what's happening in the region where the meeting is, and so this year we're going to be talking about what's happening in Germany and the surrounding areas. We are very lucky to have esteemed colleagues and speakers with us, as well as a very exciting panel session made up of people living with hepatitis B and delta as well. Today's forum is being recorded and hopefully should be available both in German and English and then posted on the Hep B Foundation and ICE-HBV YouTube pages afterwards. And I want to offer my sincere, deep thanks to the Stefan Urban Foundation for supporting today's community forum. Otherwise, we would not be able to bring this service to the community. So thank you so much to the Stefan Urban Foundation. It is my pleasure to invite our first speaker, Professor Dr. Frank Taka, who is the chairman of hepatology and gastroenterology at the Charité University in Berlin.
Yes, thank you very much, and it's a great pleasure to see you all here in Berlin, my city. I'm head of the hepatology and gastroenterology department at the Charité, which is the university hospital here in Berlin. So welcome to Berlin, and it's a pleasure to discuss with you a little bit how the hepatitis B is being treated in Germany at the moment. This is the current hepatitis B treatment landscape, and these are my potential disclosures. If you ask a German doctor, is hepatitis B increasing or decreasing, and the people look it up in the numbers, we actually saw really a stark increase in the numbers of identified hepatitis B virus cases in Germany, something between 2021 and 2022, and they keep rising. And the reason for that is that we now screen for hepatitis B, meaning really in the general population, everybody at the age of 35 years older or not is being tested for HBs antigen, or is being offered a test for HBs antigen and anti-HCV, which really leads to identifying new cases. We also have a lot of migration, particularly from the Ukraine and Eastern Europe, Syria, Arabian countries, which contribute to this increase in hepatitis B cases. For the treatment landscape, I thought I briefly review the antiviral therapy that we are using here, strategies towards functional cure, which is, I think, a really hot topic in the German community, adaptations to our management in end-stage liver diseases, and some challenges that we still face in a very developed country regarding hepatitis B. So for the antiviral therapy, I think it was Thomas Burke who introduced this concept that we have the chronic infection of hepatitis B, meaning we have the virus, but we treat only the ones that have a chronic hepatitis, so any signs of disease, which would mean either cirrhosis and HBV DNA positive, or we do have a relevant viral load plus any signs of liver disease, meaning increased transaminases, increased liver stiffness and FibroScan. But there's many other reasons for therapy, and the German guidelines, which were led by Markus Kornberg, are very liberal on other reasons when to initiate treatment. I think we basically follow what's being released by EASL this year. I think also from Markus Kornberg and his team really very active in trying to simplify the algorithm. It's not as simple as in China yet, but at least we're getting there a little bit. So one aspect, if you're on the left side, so have advanced liver disease, cirrhosis, then any sign of active viral replication would lead to treatment indication. If you're on the other side, I guess we do have instances where we have a very low risk of relevant disease, which is low viral load and no signs of liver disease. And in those cases, we would just monitor or recommend monitoring. And then we still have some cases there where you have persistently elevated transaminases, no other causes, fluctuating viral load where we can recommend treatment. And then we have the large group of patients, which is like the middle block, where we do have some signs of liver disease, relevant viral load, and in those we would recommend treatment. One aspect that I find a bit complicated in the guideline is if you have an increased risk for HCC, you should receive treatment, and that's not so easy to identify in real world. This is from the European guideline, and I think it's really a lot of fine print, which is difficult to read, but there's so many reasons why your risk of HCC may be individually increased. And for those, I think we need to really check whether that would constitute a treatment indication, particularly using the page B score. And the recommendations from the guideline is that we can use either one, entecavir, tenofovir, or tenofovir alafenamide. In the cases where we have already HCC, maybe there are some data that tenofovir is superior to entecavir, particularly for the tertiary prophylaxis of tumors. And of course, if we have advanced cirrhosis or a high risk of HCC, we should do the surveillance for HCC by ultrasound every 6 months. But even the ones that we do not treat require monitoring. And I think this has been really nicely laid out in the European guidelines, and we try to follow that. But of course, if you're not an expert for hepatitis B, that can become quite complicated. How often you need to follow which tests in case of just monitoring and not treating the patients. So for me, the key takeaways from both guidelines is when to treat and how to treat. So when to treat, of course, cirrhosis and HBV DNA positive or relevant viral replication plus signs of liver diseases. And how to treat is, I think nowadays, tenofovir, entecavir, or tenofovir alafenamide. And for Delta, I think Heiner will introduce that we regularly use bulevirtide. One aspect that seems very important, and I've actually seen a patient this morning with a reactivation of hepatitis B that still happens because I think we need to educate all our colleagues that hepatitis B can reactivate upon chemotherapy or some sorts of immune suppression. The German guidelines have a schedule or an algorithm that I would like to share with you because it first looks what's your risk from the virus side. So is it HBs antigen positive or anti-HBC positive only? And then how severe is your immune suppression? So if you have an anti-HBV positive only and you are HBs antigen negative with rituximab or some other procedures, you still have a risk which would justify preemptive therapy. If you have HBs antigen positive, then the risk is much higher, so we would initiate preemptive therapy much earlier. Even like with high-dose steroids for more than a week, we should start with the prophylactic therapy. One aspect that becomes increasingly more important in Germany is the aspect, can we achieve functional cure, meaning a sustained viral suppression without signs of liver disease, without any tablets. And I think the landmark study that we did together here with many university hospitals, led by Florian van Bommel and Thomas Berg, is the Stop-NUC trial, where they identified cases that were long negative on NUC therapy, stopped, and then compared. And I think you're all aware of the outcome. So we do get HBs antigen loss in about 10% of the cases, but a sustained remission in a relatively high number of cases. So that was implemented in the German guidelines quite early. So if HBs antigen loss occurs during therapy, we of course can discontinue antiviral therapy. After seroconversion from HBe antigen positive viral hepatitis, we can also consider after 12 months to stop therapy. But also if you're negative, have no cirrhosis, with HBV DNA negative with treatment for at least 3 years, and we now know with low quantitative HBs antigen levels, I think then those could be good candidates for a stop-NUC strategy. We have learned over the years that there's also a risk. So the risk of a hepatitis flare is substantial. It's can reach 30%. So close monitoring is very important. The EASL guidelines have also come up with an algorithm that looks complicated, so I had to split it into 2 slides. But anyway, the idea is very clear. If you lose HBs antigen, you can stop therapy. If you have a seroconversion in HBe antigen positive, you can maybe discontinue after 12 months of consolidation therapy. If you're HBe antigen negative under NUC therapy, then we can consider stop NUC if we can really sustain a close monitoring for at least 3 months, where we really pick up flares, and particularly if the bilirubin increases and coagulation gets worse, that we then initiate treatment immediately again. Of course, what will be the topic of this conference is the many new strategies for functional cure, how to interfere with the HBV cycle, gene expression, and I'm very much looking forward to the latest data that we're going to see during this conference. Maybe one word about what to change in end-stage liver disease. I think that's very relevant that we keep in mind in a liver cirrhosis, we not only dealing with the virus infection, we're dealing with a complex management of the cases, with monitoring cirrhosis complications and preventing acute and chronic liver failure, which is then a devastating condition, life-threatening, with bleeding, jaundice, and liver failure. And of course, in order to ensure that, it's very important that we take care of the lifestyle nutrition management of the patients, that we initiate therapy if they are not already on it. If HBV DNA is positive, we start also non-selective beta blockers for portal hypertension and to do surveillance for complications, meaning endoscopy and HCC screening. And we consider liver transplantation in decompensated cirrhosis or HCC. So after having presenting that to you, you may say, well, everything is perfect. We do screening, we treat the ones that require treatment, we do surveillance for the ones where we think we do not need treatment, and we cover all the complications. On the other hand, in reality, life is more complex. So even though screening is allowed, only a fraction of individuals in the general population are being offered screening. And sometimes it's that there are limited resources. The general practitioners think, okay, if I get a positive test, then it becomes really complicated, so I may not test for that. And there's a bit of a lack of expertise in that area, maybe also low awareness and stigmatization in some groups. If we have the diagnosis, sometimes it's also difficult to communicate the diagnosis. We sometimes also have uncertainties regarding biomarkers, what is really needed, sometimes limited resources, for instance, for FibroScan. If you say, well, the viral load is not that high, transaminases are normal, but I still think I want to exclude fibrosis. Sometimes language barriers, and some of the lab tests are not reimbursed on a regular basis. Regarding therapy, I guess it's sometimes a bit unclear who initiates therapy, who then prescribes, whether that can be done by the general practitioner. Is a qualified ultrasound needed very often? And even though we think the guidelines are very simple, simplified, if you look at it from a different background, not dealing with hepatitis B, you may find this all quite complex. And the monitoring as well, so we do not really have the capacity to do HCC screening like for all the patients that we identify. And sometimes it's also difficult if you don't have health insurance to get covered. And functional cure is, I think, something that requires a lot of attention, which may not be possible to do on a daily basis in a clinical routine. So with all that in mind, I guess we have enough to discuss, and I would like to conclude the current landscape of hepatitis B in Germany. So one message that is very important, so we have very good experiences with implementing HBs antigen testing as part of screening in the general population. The indications for the antiviral therapy are very clear: cirrhosis with any form of HBV DNA or elevated viral load plus signs of liver disease. We do treat with the NUCs. We need to also treat in case of preventing reactivation and immune suppression or chemotherapy. We do have new strategies for functional cure. At the moment, I think stopping NUC is the most relevant one for daily life. And in case of cirrhosis, I guess we need to reshift our focus and in addition to the antiviral therapy, also take care of nutrition, muscle mass, surveillance for portal hypertension and HCC. Thank you very much for your attention.
Thank you so much, Dr. Taka. Before we have our next speaker, can we get the countdown activated so we know how much time we have left? Thanks so much. It is my pleasure to introduce our next speaker, Dr. Heiner Wiedemeyer, who is the head and chair of the Department of Gastroenterology, Hepatology, Infectious Disease, and Endocrinology at Hanover Medical School in Germany.
Okay, so thank you very much. And again, also from my side, welcome to Berlin. Wonderful time of the year. And it's really great that this meeting is here taking place in Germany. And Barbara and Lena, this is really a super cool program, I have to say. I've been asked to briefly discuss Delta and the current treatment landscape in Germany. And a few words up front. Delta is obviously an underestimated disease, and when we became interested almost 2 decades ago in Delta, at that time I was, let's say, making up some phrases. For example, in Germany, I strongly believe that every single year there are more patients dying from Delta than from HIV infection, which we have to keep in mind. That is really an underestimated disease. The second point I want to highlight is if you treat Delta in Germany, you have also to consider migrational backgrounds, cultural habitats, how to address a disease. As in our hands, let's say 1/3 of the patients has been born in Eastern Mediterranean areas, the other third in Central Asia, former Soviet Union republics. And then we have some, let's say the rest are German-born patients with a history of injecting drug use and immigrants from other parts of the world. But if you want to treat Delta, then you have to keep this in mind, how to target really these risk groups, which is a challenge in this country. We have access to treatment. I will show you in a minute that we can bulevirtide prescribe it. We could prescribe it in Germany since 5 years now, and we were the first country where on a larger scale bulevirtide could be used, and I think it's many patients benefited from this, but still there are many patients out which have not been identified, and the standard screening that Frank just described, that since October 2021, we have a, let's say, public screening for viral hepatitis. Still many Delta patients are not picked with this screen because simply those persons who attend this general health checkup in Germany, they belong to risk groups, and they don't participate in this health checkup. And that's really an issue. And during this meeting also you have special talks and sessions around Delta. It's really an evolving field with many new developments. And for those of you who want to even learn more about Delta after this meeting, you can stay in Germany, spend another 3 or 4 weeks here, and then come to Hanover, where we will discuss during the Delta cure also some pretty new and hot things. So consider this seriously. Germany in fall is quite nice, so just stay here. And these are my potential conflict of interest. We have the European guidelines on Delta, which have been released 2 years ago. I want to highlight that in parallel, we also had national guidelines on Delta. Lisa Sandmann and Markus Kornberg were coordinating these guidelines, which is a very nice piece. Let's say some things are, let's say, same wordings in the European and the national guidelines, but not all wordings are identical. And it was for us very important to have early on a guidance how to use the new drugs. And I think the experts in Germany who are treating Delta patients, they're aware of these guidelines, giving them a frame how to apply these novel treatment options. The key message still, if you see a Delta patient in Germany, there's obviously no one-size-fits-all strategy. We are not there yet with hepatitis C. where we can treat all the patients with a short-term treatment, irrespective of, let's say, individual features, stage of disease, etc. It's a personalized treatment approach. And that holds true not only for treatment, but also for diagnostics and surveillance and all the issues around social and cultural habits also needs to be considered in this context. And keep in mind, we're always telling that Delta is the devil, the most severe form of viral hepatitis, but not every patient is developing liver cirrhosis. We have some patients who remain event-free even after 5, 10, 15 years. And in those guys, we may wait for better therapies, new therapies, but then the key question is, which are the patients who have a rather benign course of disease versus patients with a more severe course of disease? And this is something that is currently being analyzed in many real-world cohorts, including pan-European cohorts. For example, we have the data on the HBV 1000 cohorts with data from Romania, Italy, from France, and from Germany and Sweden, where these data have been combined and presented also during recent international meetings, where you can get an idea which patients are really at risk to experience disease progression. Then the other rather trivial thing is how to stage liver disease in patients with HBV infection. This is something for us in the clinic is really important, in particular if you want to tailor treatment approaches. So if somebody really needs urgently treatment now, or whether we can wait, and therefore we need non-invasive markers, and therefore it was important to really demonstrate that liver elastography also works in Delta, what would be the cutoffs to decide whether treatment is needed. And it was good news also that the rule of 5, so 10 kilopascal, 15 kilopascal are thresholds that have been established for other liver diseases, that they also work for Delta. And when you consider the risk for disease progression, also portal hypertension, I want to highlight one paper that may have been underestimated from the Vienna group and also from Lisa Sandmann from Hanover, where they measured portal pressure invasively and then correlated this with non-invasive markers and then predicting disease progression. And this is for the clinic really important data, that these non-invasive tests also work in Delta in advanced disease to select those guys who have a really high risk for disease progression. I mentioned already that we are talking in Germany about a quite diverse group of individuals. We have different genotypes worldwide, and these genotypes matter both in terms of viral sequences, when you consider also maybe new direct targets. Helene Kefalakis here summarized a large sequence series from all publicly available sequences, and she could really reveal conserved regions, but also evidence for recombination. So for those of you interested in this paper, which is quite interesting. But I want to highlight that these different viruses matter because we have different courses of outcome. Whether it's a virus or whether it's environmental factors, that, for example, in Pakistan, you have a completely different outcome as compared to North America or some African cohorts. Probably both factors may play a role, but there's a lot of research needed to really dissect these individual risk factors. When we then talk about treatment, obviously we have to treat hepatitis B virus infection, which is again not trivial, that all the patients at risk require this backbone treatment of B. We have interferon bulevirtide combinations and quite some new treatment trials. So what is the situation in Germany? Obviously interferon from the German HepNet and the Liver Foundation. We've been running the HIDD 1 and 2 trials, very well established, but let's say we have rather weak data on response-guided therapies during PEG interferon. We have no long-term cure. Even the drugs were difficult to access in the real-world setting, and therefore HBV infection in Germany is rarely treated with pegylated interferon alpha. I don't know, Thomas and Frank, whether you prescribed interferon to a Delta patient during the last 12 or 24 months. It's a rare thing. So we are left with bulevirtide. And obviously, you're all aware that initially we had this conditional approval, full approval since 2 years now. It's available in several European countries. In Germany, we could prescribe bulevirtide since September 2020. So we have a 5-year experience already of using bulevirtide. Stefan is sitting here in the audience. This audience does not need any explanation that bulevirtide is blocking NTCP. And what is also, let's say, theoretically, when there was a discussion 10, 15 years ago, the drug was supposed to be safe, and it proved to be safe. It's used in many, many patients in different registries worldwide. Yes, you have this increase in bile salts by the mode of action, but the drug is really safe. You have this daily injections, which also have been discussed. Is this an issue? I have to say, compliance, adherence to treatment, even in the long term, was rather good with Delta. So these injections are not the barrier. Obviously, it would be nice to have alternative, not to require daily injections, but it's at least for the patients that we see in Germany, that I treat in Hanover, that is not the biggest problem. We have efficacy data from the 301 study, where basically this combined endpoint, which you will discuss during this meeting, which we will discuss in Hanover, that 50% achieves this after 48 weeks. If you continue treatment, then you have, even in suboptimal responders, you gain responses over time. This has been discussed again and again. And already 2 years ago, we published the first real-world series in Germany. I run through this data because in the end, it's confirming the clinical trial. What was also interesting here, that we reported already 2 years ago, that those guys who have a suboptimal virological response still may respond biochemically. And as a hepatologist, in the end, it's nice if the virus is declining. For me, it's more important that liver enzymes normalize. And this can happen even if you have suboptimal virological response, which we published 2 years ago. We need to understand why some patients respond to treatment while others not, whether immunology plays a role, will also be discussed here. I just want to refer to one example from our group where we looked on NK cell signatures, correlated this with response to bulevirtide treatment, something we may discuss a little later. But the most important question for us now, as we have some patients being treated for 5 years, can we stop bulevirtide? This is the question which has to be answered in more detail. We have a prospective trial ongoing by the European consortium DISSOLVE, where we stop treatment prospectively, try to identify biomarkers, to identify patients who maintain response off treatment while others relapse. From the 301 trial in Amsterdam, I presented the final data where we could see that after 144 weeks of treatment, if those guys who were at HBV RNA undetectable, you can see here that some patients maintained the response of treatment for 2 years, which I think is quite remarkable in the presence of S antigen, that these guys did not relapse. And the most important factor was duration of being undetectable during treatment. If patients have been undetectable for 2 years, you may stop. 9 out of 10 patients here made it in the 301 trial, and this obviously needs to be confirmed prospectively. We also could show that the drug is even effective off-label in patients with decompensated cirrhosis, which I think is an important message. For us in the clinic, it's quite challenging. If you have a patient with child B cirrhosis, you have a drug where you know it works, but officially it's off-label, are there reimbursement issues, and these are different regulations in different countries. This data clearly supports use of bulevirtide also in cirrhotic patients. And lastly, obviously, even though we don't prescribe interferon a lot, the big question is, should we combine this with bulevirtide and interferon? Synergistic effects have been demonstrated. Even some patients in this setting may lose S antigen. But when you have a careful look at the phase 2 study, the 204 study, it's quite clear that the long-term off-treatment HBV RNA undetectability rates were not different between the combination arm with 2 milligram and interferon alone. 10 milligram is not available. It may be approved maybe next year or so. We have to see how the FDA deals with this, but this is certainly something which needs to be explored in more detail. I don't talk about the new drugs which are currently being developed in phase 2 and some of them in phase 3 trials. Interesting approaches will also be discussed during this meeting. My take-home messages are really that theoretically interferon is still a treatment option, in particular if bulevirtide is not available. But on the other hand, PEG interferon needs to be available, which can be an issue. Then the questions around bulevirtide I mentioned. The good news is also that beyond bulevirtide, there are new treatments in clinical development. Thank you very much.
Thank you so much, Dr. Wiedemeyer. I am very happy to bring up our next speaker. Dr. Thomas Berg is head of the Division of Hepatology and Deputy Director of the Department of Medicine at the Leipzig University Medical Center in Germany, and Chair of the University Liver Tumor Center and Vice Chair of the University Liver Transplant Center, Leipzig.
Yeah, thank you so much, dear colleagues, dear organizers, for inviting me to give a short overview on epidemiology and progress and challenges with the elimination program for hepatitis B and Delta. And I think Frank just mentioned it. I think there's a key issue and a key change in our landscape for hepatitis B and C virus. And this is the introduction of a kind of a general screening for these viruses. And what it's behind is, as you can see here, the integration is for all Germany's statutory checkup program. This means that all being in the healthcare system in Germany and are in the age of 35 or beyond or older could have once in the lifetime, as part of a kind of a general health check where you check for cholesterol or hypertension and diabetes, that you can get in addition with some reimbursement for the primary care physicians an hepatitis B and C test with reflex testing for the DNA and RNA. And the patient should be also informed, or the people should be also informed for risk factors for hepatitis B and C virus infection. And we did a large study comparing what does it mean for the primary care physician in terms of testing after the introduction of these general health care checkup. And what you can see here, that we compared the numbers that has been screened for hepatitis B and C here together before the introduction. This was in 2018 and 2019. And thereafter. And what we did here, and you see the numbers, it covers around 70% of the primary care physician healthcare system, what has been done here. And you see in 2018, there were 30,000 HBs antigen lab requests, and in 21, it was nearly tenfold the numbers with nearly 290,000 tests for hepatitis B. And you can see here on the right-hand side that most and much more, of course, of positive tests resulted from this surveillance, and most of them were by screening and not because it was ordered because of elevated ALT or something else. And we got also kind of data on the prevalence of HBs antigen by this study, and you see the prevalence of HBs antigen was 0.45%. 54%. I'm sorry for the quality of some of these slides. This is by the transforming from Apple to Windows. But what is shown here, that in all age groups, and this is for males, but also for females, you see the effect in screening in terms of the percentage increase in HBs antigen positive results, starting from 160 to 900% in males, and you see in females similar numbers. So how does it impact our reporting system? And by law, every positive test for hepatitis B, also C, should be reported to the Robert Koch Institute. This is a German National Public Health Institute and central body for mandatory infectious disease reporting. And you see what happened before. These were the reported cases by year and stage of the infection, was acute or chronic. And you see there was a change in the definition that clinical symptoms does not have anymore to be included. And this was in 2015. There was already a slight increase in the number of reported cases. But now with the screening with the general health professionals, there's a dramatic increase. You see most of the infections were chronic, some acute, and this seems to be more or less stable. But you see also we have still issues with the quality of data, although it's in a kind mandatory to let us know whether it's chronic, acute, or so on. You can also say, well, it's unknown, and you see large proportion is still unknown, but likely it's a chronic infection. In terms of the age distribution and gender, you see clearly the most prominent effect is starting with the age of 30, 35, when the health check-up 35 started, and there were more male infected as expected. We can also break down the numbers according to the federal states, and you can see here, I'm really sorry for the quality, but the upper part of this graph, these are mainly the federal states from the former GDR, so the eastern part of Germany, where the frequency and the prevalence is much lower, and the highest prevalence we have in the big cities, in Hamburg, Berlin, and Bremen, perhaps related to certain risk behaviors. We also mentioned migration, and these are data from 2018 estimating that the relative contribution of migrants to the total number of HBV infected cases is, as you can see here, 50%. But this is already some time ago where these data were reported, and I'm not sure whether this relative contribution still holds true. If you look at the current evaluation from the Robert Koch Institute, you see here that of the huge number of patients, and in 2024, nearly 22,000 infections were reported by this reporting system. Unfortunately, as I mentioned, nearly 10,000, the country of birth is unknown, but only 2,500 are from Germany. So perhaps we have underestimated so far the role, let's say, of country of birth or migration. But you see, again, we have here an issue in quality. There are certain risk factors missing in the data. So we do not have good data on MSM, prisoners, and this is a kind of a prediction or an estimate in this population. And I'm really sorry for the quality again, but according to this estimate in the general population, it should be 0.2. And I think the numbers are higher. I've shown you in our study 0.5. In pregnant women, 0.22%. In first-time blood donors, it's very low with 0.05. In MSM, it's nearly 1%. In person who inject drug, also 0.78. Same in prisoners, and in migrants, the estimate is 2.5% to show you the numbers. So what are the challenges in hepatitis B virus infection? And there's a recent ECDC technical report about the monitoring of the responses to hepatitis B in the EU and EEA countries in 2013. And what you can see here, there's always in this dotted line the WHO interim target for 2025. And you see here in terms of the proportion of all people living with chronic hepatitis B virus infection ever diagnosed, we do not really have data for Germany, and also in many other countries is missing. The same holds true for people ever diagnosed and linked to care. Again, no data for Germany. And in terms of the percentage of people being treated, here we have numbers for Germany, but of course with a bit more than 10%, this is the estimate from this study, we are very much below the interim targets of the WHO. These are the data from the Polaris Observatory. There it's believed that the number of diagnosed people in Germany with HBs antigen is 37%, with 31% of them being on treatment. Are there any treatment restrictions? Well, yes, for HBV if you are undocumented migrants. And what about late diagnosis? Difficult to get this information, but the estimate is that 6 to nearly 30% when first diagnosed have already a cirrhosis, and 2 to 10% hepatocellular carcinoma. So what are the key challenges for hepatitis B? I think to really fulfill the mission of elimination, of course, epidemiological data are a bit insufficient, outdated, missing prevalence estimates for HBV. There's a large undiagnosed population. Late diagnosis is an issue, and there are gaps in the risk group data, as I've shown you. Especially, we do not have a system that allows us to calculate linkage to care. There are policy gaps I mentioned with treatment restrictions, and the checkup 35 screening is of course a good opportunity, but uptake still limited, so it's not done in all patients going to the checkup, and we have certainly an insufficient coverage of high prevalence groups because perhaps many of them will not go to this regular healthcare checkup. In the last couple of minutes, I want to briefly mention hepatitis Delta virus infection situation in terms of epidemiology, even more complicated. But I think that the main message is that the prevalence in most of the countries is lower than previously assumed, and this was the adjusted estimate study done again by the also Polaris group, showing that in terms of what was reported with an about 5% anti-delta for all HBs antigen positive people, it's perhaps less than a half, and if you go for the HDV RNA, it's even less. This shows you the data again with the so-called landmark Stockdale study in 2022. So if we go for 215,000 HBs positive, the literature was 5.5 being anti-delta positive. The adjusted anti-delta will be 3%, means 6,500 RNA positive cases, but after adjustment, it will be only 60%, so we end up with 3,900. This means 2% of the HBs antigen positive patients harboring HDV RNA. This means you have to test 33 HBs antigen positive patients or people to detect one delta viremic infection. These are the number reported by the to the Robert Koch Institute, and again you see the effect of this more global checkup 35 screening, where the numbers are increasing starting from 2022, and overall it's around 100 to 120 people being reported as delta positive, and this means RNA. Again, the age group, you see a male predominance in the age of 40, but then a bit higher prevalence of females. And again, here we are missing information about the country of infection. And you see unknown, this is the last line in row, that it's in 75% we do not have this information. And in the 29 patients out of these more than 100 with the information, 50 are coming from Germany, but you see here also the patients from all the different other countries. The second most common now Ukraine, and of course this can certainly be rapidly changed, and this shows you that compared even with May 2025 and end of June, we have an additional of 3,800, 0.3% people coming from Ukraine. And Ukraine, the prevalence of anti-Delta is not low. So just showing you that by migration, these numbers might be volatile. I want to conclude my talk by a study we did where we first had a retrospective part trying to evaluate how often the recommended testing for anti-Delta, if HBs antigen is positive, has been done in large laboratory centers. And we started with HBs antigen positive tests in the years 2014 and 20 of 14,000 tests. But the surprising result, or perhaps not so surprising, that only 20 of them were tested for anti-Delta, and of this selected group, because 11,000 were not tested, although HBs antigen positive, the anti-Delta prevalence was 5%. And again, here, 60% of those did not get an HDV RNA test, and from the 40% that got the test, 46%, less than half, were positive for Delta. And you see the highest, if you like, reflex testing for anti-Delta in HBs antigen positives was done in primary care, less so in hospitals, and in occupational medicine, even less. And if you go for asylum centers, it was done in only one case. Over the years, there was no change, although there's education guidelines. So the percentage of people with HBs antigen being tested in this study was 20%. And then we did a prospective study after the implementation of this screening and a similar 12-month period. And there were 225 individuals who underwent the checkup examination. And we found again 0.5% HBs antigen positive. And you see 60% of them then could be tested for anti-Delta antibodies, with 18 out of 700 were with 2.6% had a positive results. So you may wonder why only 700, because this was part of the project that we had a kind of a reflex testing for Delta. And this shows you some practical challenges, that there was the limited feasibility for reflex testing just because it was not enough sample anymore, or as a sample need to be shipped to a different laboratory for a test that could not be provided in this specific laboratory, and also communication and logistic errors. These are the numbers, or the people being infected, and just to show you that then we tried to do a look back in order to be aware what kind of patients these are, these 18 patients with anti-Delta, and to go for HDV. And here you see the issue. If you do not have reflex testing, we could also only trace 4 patients, and out of these 4, only 1 was positive. So to summarize the implication of anti-HDV screening in primary care, I think it gives us for the first time evidence on the anti-HDV prevalence. It seems to be around 2% in primary care. There is again, as I mentioned, a gap in the risk group coverage and the need for complementary strategies like these reflex testing. Thank you very much.
Thank you so much to Professor Berg. We are now going to open it up to our panel session. And to moderate that, I'm happy to introduce Dr. Thomas Tu, Associate Professor, and also he leads a research group at Westmead Institute for Medical Research at the Store Liver Centre in Sydney, Australia. And Dr. Tu is also founder and director of hepbcommunity.org, a global support network for people affected by hepatitis B and Delta.
Right. Thank you, everyone. And I'd like to thank the previous speakers for giving us a bit more about the numbers around the world, around Germany, about hepatitis B and Delta. But really, behind each number and percentage is a person, is a story, is a full life. And we should never forget that. And I applaud the organizers for inviting so many diverse viewpoints here today. We've got 5 speakers. We've got Amanda and Silvana online. We've got Partisan, Natalia, and Cosmin sitting here with us. Because we need that diversity of viewpoints. Generally, when I was being invited on panels, I was myself the only one with lived experience there, and 300 million people can't really be represented by one person. So we have these people here, and they're going to share a bit about their experiences and stories, and it's not so we know who to pity. It's not necessarily just for you to be inspired and feel useful, but it's actually to know who to work with and partner with to get shit done, because it needs to get done, as you've seen by the numbers. These are the people who can guide us to be most effective in delivering care where it's needed and to know what problems science needs to solve to be useful, okay? So with that in mind, I'd like to invite our panelists to introduce themselves. Can we get the remote speakers up? Are they there? Do we have online speakers? We couldn't get that done? Okay. Then we'll have to go, oh, there we go, thank you. Great. So Amanda, I'll get you first to introduce yourself in a couple of minutes, for a couple of minutes.
So, hi, I'm Amanda Goldring. I live in the UK, in Cornwall, which is the southwest peninsula. I was diagnosed with hepatitis B purely by chance in 2019. I was diagnosed with Crohn's, and from that diagnosis, I was also diagnosed with hepatitis B. But without my Crohn's diagnosis, I would still be unaware, and I dread to think what would happen.
Thanks, Amanda. Silvana, you next.
I'm Silvana, and I live in Bulgaria, and I was diagnosed with hepatitis B almost 20 years ago. And at that time I was lost and I didn't know what hepatitis is. But, you know, it takes time and devotion. It takes a lot of self-learning and care. And I think patients, as you said, should not be pitied. And we can become so much stronger with time. We just need support and to know that we are not alone.
Thanks, Silvana. Natalia, please.
Okay, it's working. Hello, everyone. I'm Natalia. I'm 39 years old. And my HBV chapter began 7 years ago when I was diagnosed during my first pregnancy. And it came as a blow, but the second one, the heavier one, came just after I gave birth to my second child. I was put on antiviral medication. I was told also it was going to be a lifelong medication. It was also a very vulnerable moment for me as a new mum. I was breastfeeding and I was told that I would have to stop. So I'm really glad to hear that there is, in Germany at least, this tenure of 3 years after which there is an option of giving up medication, but let's see how successful it is elsewhere. Thank you.
Thanks. And Partisan? Yep. Yep. Oh, Cosmin.
I am Cosmin Oprea from Romania, founder of a creative initiative with the aim of increasing awareness about hepatitis B and Delta. I have been living with hepatitis B since I was a baby, and my experience, personality, and circumstances with my mother with no history of hepatitis B have allowed me to connect my immunological traits at birth, such as the absence or presence of maternal hepatitis B antibodies, with my current scenario. Additionally, based on this observation, it was reasonable to consider that this factor might influence different outcomes in chronic hepatitis B. My approach was based on intuition and creativity with the goal of comprehending an extensive picture, with the possibility that the ideas generated could facilitate a better understanding of this neglected disease. I am a hepatitis B storyteller with Hepatitis B Foundation since the beginning of 2024, and I am grateful and honored to be invited at this community forum.
Thanks. And Partizan.
Hello, everyone. I'm Partizan Malkai. I come from Tirana, Albania. I'm a patient with hepatitis B, but for some years, the hepatitis is inactive. But I have a familiar experience about this because my wife, 18 years ago, underwent liver transplant from cirrhosis of hepatitis B. So together we face this situation and enjoy our life every day, every year, every week. We like to help the other peoples that have life experience with hepatitis B, D, and C in Albania. So we created the organization of patients with hepatitis in Albania 14 years ago. We like to help these peoples to find solution for different problems that has to do with their education, with drugs, with to help with the medical health system in Albania that in some situation have a gap to cover the examination, the screening about the problems with hepatitis B and hepatitis D. We want to know that these people are not alone. We want to know that these people need to enjoy their life every day as us. It's very, very, very important for them, for us together. Thank you very much.
Thank you. Great. Thank you all for sharing your stories. We really appreciate it. So we're about to, after this session, hold a very technical meeting about hepatitis B, a lot of molecular biology and research and very phosphorylation of all this sort of thing. I guess during all of your journeys with hepatitis B and Delta, you learn things on the way that perhaps you thought should be more common and maybe that these scientists take for granted. Can you share a bit about what you think should be, what kind of information should be more promoted amongst the people living with hepatitis B? Does anyone want to go first? Oh, Silvana, please.
As I said, patients could either feel devastated by the disease or a patient could make a choice to make something from it. It's not just living with hepatitis B. We have a lot of other diseases and we need to learn and we need to adapt. So for me, it's not just, oh, I have hepatitis B and I just need to look straight forward. Actually, we have a lifestyle to manage. So patients just, they need much more information, not just that they need to take one pill a day and that's all. We need to know how to eat, how to exercise, how to manage our comorbidities, especially for women in my age. How hepatitis B and how the treatment affects on perimenopause and menopause. Because everything, it's all connected in our body. It's not just the liver. Every system is connected with the liver and with hormones and with, the treatment. So I think for me, it's, we need to discuss two things. First is that patients should not be afraid or ashamed from the disease, by the disease. And they could make a really great choice what to do from now on. Either they can stay in the dark alone, or they can go up front and say, okay, I have this disease. It came in my life for some reason. I need to know how to move on and how to have happy life and how to live fulfilled life and how to have meaningful life and how maybe I could motivate the other patients around me. because as I said, I was diagnosed almost 20 years ago, but at that point I started to think, okay, what can I do? I became part of a patient association. I'm running informative campaigns. I'm part of the advisory board of the Hep B foundations. And I think that patients are not just person with viruses inside. We are so much more, but we need information. We need to know how to manage our lives beyond the pill, the everyday pill. We need to know about how to make ourselves better, how to not to, be depressed about the disease, but we need to know how to manage our comorbidities and how everything is related. As I said, especially for me as women in perimenopause, I need to know more about how the treatment affects my liver, my hormones, how everything is connected. So I think that patients need more about that. And of course, about clinical trials.
Okay. Thanks, Silvana. Amanda.
Sorry, can I just back up what Silvana said about being in a very dark place? I don't think people realize that when you're diagnosed, it comes as such a shock. And I went from being what I feel like a happy, normal, well person, and within a phone call, my life was in a heartbeat was turned upside down completely. And I cried for days and days and days and thought, this can't be me, there must be a mistake, which of course there wasn't. But for years, I lived in what felt like a dark cave where there was no light at all, until I decided that I couldn't live like this. There must be another way to live. And I turned my life around. I felt like I needed to shine a light on hepatitis B because there is no information out there.
Yeah.
You go to the internet and you just get horror stories, and it just makes life worse. We need good information, reliable information, not that you get from the internet. We need information that empowers us and empowers us to fight, not to just go in on ourselves and feel like we're victims.
Yeah, great. Does anyone, please, Cosmo.
From some of us, hepatitis was a silent infection, while for others has been a severe challenge. Summarizing my personal experience with hepatitis B is not easy because I realized that my life and especially my childhood were very impacted by this experience. While I don't remember all the chronology, discussion with my parents led me to understand that I have been living with hepatitis B as early as 1 year old, and the positivity of hepatitis B was the only proof of my condition. Notably, no one in my family has a history of hepatitis B, and particularly significant, my mother has not been exposed to hepatitis B. My childhood was marked by frequent hospital visits and blood tests, and my family has made all the effort to keep this situation private and hidden, to protect me for any stigma and discrimination. This puzzle about frequent hospital visits, particularly in the absence of medical symptoms, have led me with infinite question about why we are periodically going back to these sterile environments if my situation was normal. Reflecting over my past, I admit that I was deeply worried by these events, but my parents surrounded me with their compassion and protection. While my family and my social cycles were my foundation of trust and development, this circumstance with external stressors such as hepatitis B have contributed to anxiety and made me feel that I was somehow alone. When you grow up with an infectious disease that concomitantly required hiding your condition and medical investigation, your perception and feelings about safety might be different than anyone else. While I was already overwhelmed by medical tests and uncertainty, I wasn't prepared for the next challenges that included approximately 2 years of interferon and 3 liver biopsies. I remember that I received 3 injections per week for 1 year, while in the second I received 2 per week. All these injections were done at the local hospital, while the biopsies were effectuated in the capital. I have blurry memories of that period, but I remember liver biopsies very well. While school has been always a method for me to cope with my situation, during my 5th grade year, I was in the position to give up to my scholar year because of the side effects of the interferon. As I mentioned earlier, my hepatitis B was kept private and hidden, amplifying the challenges we faced. Despite this unpleasant experience, and after this pause, I have managed to return to the same school and obtain good results, but I can say now that the period leading up to the second start of my 5th grade year was extremely difficult. This experience have led me with a lot of neurodivergent traits. My thoughts were that the number of hospital visits will be reduced after interferon, but my mother began to confront her own medical issues, which resulted in collection of pus and lasted for almost 2 decades. With these new challenges, the role of my mother and I changed. Between life unpredictable events, I was lucky along in this journey. I met my wife, and her presence came with love and support. The subject of hepatitis B was kept as a simple infection, and I asked my wife to keep this situation private, somehow challenging our whole situation. From this love story, our precious girl came into our life. Shortly after, I was tested for hepatitis delta, and I embarked on another 2 years of interferon. This period was difficult and marked by physical and emotional challenges. Concomitantly, my third daughter was quite young, and my mother problems continued. Having already fragmented my childhood memories, this time my interferon treatment interfered with the childhood of my daughter. During this challenging time, my wife was always my foundation of support. By the weight of these experiences, often overwhelming. At that time, interferon was the only treatment available for hepatitis delta, and the side effects were quite harsh. I faced depression and anxiety, and my wife made all the efforts to help me with this problem, but I wasn't ready to confront all my fears and my fragmented childhood memories. Sadly, my mother left the world at the age of 49, leaving me with infinite questions. In the background of this challenging experience, I listened to my own emotions and intuition, and I reconnected with my ignored child goal of working in hepatitis B. This made me to understand that my own challenges represent a common experience. Working with myself, I realized that hepatitis B is firstly associated with unknown, self-stigmatization, and discrimination. In 2019, I took the decision to launch a creative initiative and share a part of this story with the aim of encouraging people with similar experience. My intention were and are to provide listening and support for individuals living with these conditions, because I am aware that hepatitis B is more than a diagnosis, and the challenges faced by the hepatitis B community are often a result of complex circumstances. I have personally struggled with depression and anxiety. And during the interferon, these feelings were more intensified with harsh side effects. Reflecting over my personal experiences, the idea of undertaking research has been intensified by my own experience and made me to share my personal data openly in 2023, because my aim has been always to comprehend hepatitis B in newborns with the goal of preventing new infections. Thank you.
Thank you. Thank you all for sort of sharing and making sure people understand that this is something that affects an entire person and is not a puzzle in itself and something that is to be solved. It is there. We need to be helping people and treating people. So we're almost getting to the end of our time. So I want to give you all an opportunity to really put forward to the scientists here in the room to make sure that they hear what you think are the most, should be prioritized most, and what they need to hear. Does anyone want to give their 2 minutes worth of?
It's something that I understand very well. In daily life, I am a lecturer of applied physics in medicine and bioengineering. I am lecturer in the Polytechnic University for more than 30 years. I have a lot of scientific publication about the use of methods of physics in radiotherapy for patients with different cancer tumors. So me and my group have a good collaboration with patients. We know the psychology of these patients. I want to say that in this case, when we speak for treatment of hepatitis B and D, we need to, the first way is to building bridges between scientists and peoples with life experience. Not to see these people as target group. For me, it's very wrong. But to see these people as collaborators, to have a good results in our studies. For me, it's very, very interesting because these things have to do with the psychological situation of this patient, of these peoples that suffer in any way. The second way, I think, has to do with the creating joint group between scientists and people with life experience for advocacy. And the third way, I think, in my opinion, has to do that these people need a more human approach on the part of the scientists for their problem. How to do this? Maybe in a way has to do with creating a joint group in scientific conference, in forums like this, or in different congress. That's very important for the people with life experience to feel better, to know that they are not alone in this situation. Thank you.
Thanks.
If I just may, on the back of
Yeah,
that,
please.
I'd like to echo everything you've said. And when it comes to the scientists and doctors, I believe you should look at it as giving us our life back in a sense, right? It's not just the liver, it's the roller coaster of emotions that we have to go through every day. And not us, only us, but families, right? People who are close to us who might not fully understand what's happening, but they are affected. And I think this mental load and the anxiety is the worst.
Yeah.
So that would be it from me for now.
Thank you. Silvana.
Yeah, I think it's important to mention that we should think about patients who goes in clinical trials with high hopes of the outcomes, and when nothing happens, they might feel devastated, and those patients need support, psychological support. So I would strongly suggest that if there is a possibility, clinical trials should include also psychological help. Because I was included in clinical trial 1 year long, and when I didn't get the outcomes I was hoping, I really could share that I felt, well, not devastated, but I felt that I just drop out of the clinical trial, and I was left alone. And patient needs to deal with those emotions, and most of the patients are choosing not to share those emotions with family because they don't want to worry them. So patients not only need support for the body and the liver, but also for the mind. So I would strongly suggest to look to hepatitis B, not only like a disease that affects the body, but also the psychological and emotional aspect of patients. And this is something that I would strongly advocate from now on. Thank you.
Thank you. Amanda.
So I'd like to end by saying that that I would like you to hear us and see us, as up to now I feel that we've been invisible and nobody has cared. And I want to promise that you will insist that you do all that you can to end this living nightmare that we live in.
Thank you, Amanda. Oh, yeah, please, Heiner.
May I just add one comment? I think all the issues around well-being, stigma, need data. I think that's absolutely critical. We will have new drugs close to the market soon, and the discussions that we will have in Germany, for example, is really what does it mean if you lose S, if you have some kind of cure. We're talking about an infectious disease, but then there's the usual discussion that you can control the virus with the currently available drugs, but the additional value of losing S, of controlling an infection, if we go to our boards in Germany, it will be quite hard for them to accept this unless patients stand up, unless we have in each clinical trial hard data that we can really show that this infectious disease is affecting the well-being of individuals and that having a new drug improves this well-being. We lack data, and anybody in the room who have regional data, just cross-sectional, large cohorts will help us, for example, for the discussions here in Germany. This is really an absolute critical point to highlight. We are not talking about a liver disease, the risk of cancer. We're talking about an infectious disease affecting the well-being of individuals, as we impressively heard from all over here. Yeah. So we need data.
I agree, but those studies need to be resourced. I mean, there has been a lot of good work and good people intending to do a lot of these, but getting that funding is still difficult. Shari, please.
Yeah, just to build on that, I think you are absolutely right. And one of the things that we should be, what we are doing in a small scale with the funding we have, is looking how do we do that? So how do we collect and document and rigorously document that? I think patient-reported outcomes using validated instruments throughout the clinical trial process, this is exactly what we need. So we need to be advocating and pushing for, and as researchers working together to make sure that the clinical trials that are coming down the pike have this in there. You know, how do we collect data and document quality of life before treatment, during treatment, and after treatment, during clinical trials, and also during clinical management? That is exactly what we need, and hopefully we can kind of agree as a community to work towards that.
Mm-hmm. And I think throughout all of this, these studies, there needs to be involvement from the lived experience and affected community. For more practical sort of guidance for that, we have recently written a paper on best practices on engaging with the affected community. Happy to circulate though. But these are, you know, concrete principles that you can bring into your practice and study to make your work a lot more effective. With that, I think I'll hand over to Shari for the Q&A. Oh, I'd first like to thank all of our lived experience panel and thank them for their bravery, for being vulnerable in front of all of us. We owe them a big thanks for their work and their sort of sacrifice for bringing you this knowledge and information and experience.
I can actually just do this from here. Thomas, if you want to stay there or sit down. I do want to we have time, just maybe a couple of minutes for audience Q&A. I know that there are probably some questions online, but first I'd really like to hear from people in the audience, from you guys.
Jake Lian-Fan, is this working?
Yep.
Jake Lian-Fan, NIH. Perhaps us as a clinician, investigator, and advocacy should try to link more hepatitis B to cancer, right? I mean, it is a cancer-causing virus, probably one of the very few documented. And I think it's very important. I certainly was amazed at what Thomas showed the data in Germany. Actually, quite a few patients was diagnosed hepatitis B when they presented with liver cancer, right? I mean, I think that's something that we should always keep in mind, that if we diagnose early, we can prevent the cancer. Or if we vaccinate these people when they're younger, before they get the virus, we can prevent cancer. So I think this is very important to make that linkage. I really wish when we go out on the road to advocate for hepatitis B, make that connections, because people can much more identify with cancer as well. I mean, not to mention other issues, but I just think that's very important to think about as we advocate for the importance of studying hepatitis B. So.
Yeah, Jack, thanks a lot. And I couldn't agree more. And this is always my saying, that also from a policy change argument, or when you talk to politicians, they easily understand cancer and cancer prevention, and it's on the agenda of the European Commission. It's much more difficult to understand fibrosis progression and so on. So I think clearly that's a very good argument to make people more aware how we can prevent this outcome.
Jake, I agree, but a slight word of concern. HBV causes cancer, and as Thomas mentioned, politicians understand this. But in clinical trials, as an endpoint, obviously we will never be able to show that we can present with a new S-antigen curative treatment the prevention of cancer in the short term. In the long term, this is important, but then I always get the question, what would be the number needed to treat for a new drug, clearing S, to prevent one case of cancer in an otherwise rather healthy population? So we have to be, for politicians, it's a very good message. For these health technology assessment guys, it can be a dangerous discussion.
Does anyone from the lived experience want to comment on emphasizing cancer?
So the question is whether this would be useful in terms of getting more patients to get screened.
And maybe getting more prioritization for funding and research.
Oh no, that definitely, that should be a priority. And I think for example, from my experience, when I was first diagnosed, there was no mention of cancer. And no one said it to me. It was at a later stage when I did my research, when I did a bit of digging, that I found out, okay, that's hopefully not the outcome for me, but an option certainly. And it adds to the stress, it adds to the anxiety. It makes life more difficult, having that in mind, bearing that in mind, that this can lead to cirrhosis or liver cancer indeed.
Thank you. Thanks very much. John?
Hi, excuse me, my name is John Tavis. I'm a professor at St. Louis University. I also am former chairperson of ICE-HBV that organized this, and among the other things I do to cover my bald head is I direct a drug discovery institute. And what I want to speak to the panelists or the lived experience people, I want to tell you that we hear you. We hear you and we appreciate you. There's a room full of people here who are all virus nerds. I mean, we are really into the weeds on how this virus works. But we hear you, we know where we need to go, and we're doing our very best for you. And so I want to say thank you very much, and I just wanted to let you know that we hear you.
Thank you. Peter Revel from Australia. I too echo John's thoughts and thank our lived experience people for sharing your experiences with us today. But I have a very, very naive question for Heine, Thomas and Frank. We have the EASL guidelines, we have the AASLD guidelines, the APASL guidelines, the WHO guidelines, the Chinese guidelines, the Australian guidelines. Can we ever just have one guidelines?
Wouldn't that be nice? Yes.
And how can we do that?
So this is something we're actually working on, and we should talk about this. I mean, this is something that I think the public health and lived experience community is advocating for. We actually just published a paper with Dr. Su Wong as primary author on yes, how can we bring together all of the guidelines and align all of the global guidelines. And as a first step, even aligning terminology, we don't even call the different stages of the disease the same thing around the world. And so you are correct. I think having the scientific community on board with this, and the more voices we hear about this, the more we can get it done. But I think that would be an incredible goal.
Thank you.
Yeah, thank you. Joan?
Hi, I'm Joan Block. I'm one of the co-founders of the Hepatitis B Foundation. I have been in this space for 35 years. I'm not here as a data person. I'm here as an advocate and also a cheerleader. There are three observations I want to make from today, is particularly the lived panel, is I am very glad to see 5 people living with hepatitis B who are not Asian. So often it seems to be an Asian problem, but again, the fact that the 5 of you have participated and shared publicly your stories indicates it's a global problem. So for that, thank you to the 5 of you. And I know it takes a lot of courage to speak up publicly. I did not speak about my living with hepatitis B until I retired from the Hepatitis B Foundation. So you guys are way ahead of me. The second observation I wanted to make was that for those of you who are relatively new to your diagnoses, we have come a long way. My husband and I, Tim, came to the HBV meeting first in 1995. There was no talk about lived experience. It was all about how interesting the virus was. What an interesting virus, what an interesting problem. And I remember Tim asking somebody, what about the people living with it? Oh, what? I don't know anything about the disease. I just think it's an elegant virus. That is how somebody said it. So in 35 years, we have progressed from an elegant virus to actually inviting people who live with the disease to share. And then the third thing I want to say is this is both thanking the HBV meeting coordinators for inviting all of us to come speak. This is relatively new, and I credit Dr. Sherry Cohen, the current HBF president, as starting the whole storytelling project at the foundation. Without that project, you all would not be here, and I would not have probably shared my story. And I think because of that storytelling project, we now have people all around the world, in the US, and now I've discovered UK and Albania, and I'm sorry, so I can't remember where you're from, but from all around the world. And so I do want to thank the HBV meeting organizers for agreeing to this. I'd like to thank the ICE-HBV group, Peter Ravel, who first encouraged this, and thanks Sherry and Thomas too for coming out and starting the Hep B community. So thank you to all of you. We have a lot of work to do, but now we have everybody in the room. We have clinicians, we have scientists, and I want to echo what John Tavis just said. These are the people here in the room, the scientists who discover the cures. And we have Ray Shanazi, Stefan Urban, who Ray Shanazi discovered the first oral drug for Hep B, and Dr. Stefan Urban has the latest new drug. And there are going to be lots more. There is going to be a cure in your lifetime, maybe not mine, but in you younger folks. So thank you.
And Joan, I just want to thank you for walking the path ahead, and at least in my case, I stand on your shoulders in terms of being able to feel safe enough to sort of publicize my status, so thank you.
Yes, I agree. Thank you, Joan. We wouldn't be here if it weren't for you, and want to thank everybody for today. To close us out, I would like to invite Professor Maura Dandry up, who is the current chair of ICE-HBV.
Oh, I need to hand out
Oh,
awards.
sorry. We have to do awards first. I totally forgot. Okay. I would like to re-invite Thomas Tu up to do awards from Hep B Community.
Thank you again to our panel. Thanks, Johanna. Okay, great. So I have got the great privilege of awarding a whole bunch of awards, and this is for the 4th edition of the Research Showcase for Hepatitis B Community.org. Thank you. So, one of the major reasons why I set up hepbcommunity.org was to encourage more conversations between the scientific and affected communities so we can all learn from each other. And I thought what would help would be that the researchers could provide, a lay summary to the affected community and start discussing one-on-one their work and get some sort of insights and start those conversations. And it was really a way for the affected community to provide feedback to researchers and ensure that the scientific progress would be guided and directed to the most important issues that are affecting the lives of people living with Hep B. And so to address this, we invited Hep B researchers from around the world to present their work at our Research Showcase event on the forum. So the researchers describe why their research is so important, how they do it, and what's exciting in an interactive thread. So this year we've had a significant increase in the number of research entries, and we're really glad to see 22 researchers publishing their research on the forum, almost 4,000 views, and that's just registered views. There are a whole lot more people who were not logged in. About the same number that were not logged in reading this. So a huge amount of promotion of their work. And this allowed us, we were fortunate enough to offer 9 awards this year, 4 for the affected community members, or 3 for the affected community members asking the best questions, and 5 for the researchers starting the best scientific discussions. And all of these were selected by the community, a very democratic voting from the users of hepbcommunity.org in a very open process. So in this Research Showcase, we've had a variety of entrants, and we have to thank all of these sponsors for allowing us to give out cash prizes to the people who engaged in this research. So first off, we will give out the Curiosity Awards for the affected community members for their best questions and comments, and each one of these comes with a $100 US prize. And the first Curiosity Award was sponsored by Hep B Voices Australia, and so I'm a co-founder, deputy chair, and secretary of this community group, and have the privilege of reading out some prepared remarks from our chair, Nafisa Youssef. So she says she's the board chair of Hep B Voices Australia, which is the first hepatitis B community peer-led organisation in Australia that is wholly led by people living with hepatitis B. And our purpose is to amplify the voices of communities affected by Hep B. She says that this event truly celebrates the partnership between researchers and affected community, and she's delighted to present this year's Research Showcase Curiosity Award to Caroline Harold, and so we congratulate her. Next up, we have Lucy Klein from Hepatitis Australia to award the Hepatitis Australia Curiosity Award. Hepatitis Australia is the peak community organisation to progress national action on issues of importance to people living and affected by hepatitis B and hepatitis C, and hopefully this plays.
Hepatitis Australia is really pleased to sponsor this year's Curiosity Award, and our congratulations to Bright Ansar on winning this year's award. It's really fabulous to see hepbcommunity.org creating this forum to bring research and community together in such an amazing and positive way. Genotype research offers so much potential to tell us why and how hepatitis B looks different in different people, and we're really pleased to be able to support this opportunity. Congratulations.
And next up, the Hepatitis B Foundation Awards, and we've got Shari Cohen here to give a, oh, you've got a mic.
Sure, thank you. I don't know if our two winners are here. I thought maybe at least one of them would be, but the Hepatitis B Foundation is very happy to give out these two Curiosity Awards. The first one is to Tom Adamati for his engagement on the topic of superinfection therapy, rewriting the antiviral playbook. And I don't see Tom, at least not yet. And also to Oyindamola Okunola for their engagement on the topic of using CRISPR to target and cut HBV RNAs to stop replication and production of HBV protein. So congratulations to these winners.
Thank you. And now we have the Community Awards, and these are awarded to researchers who've created the most engaging and helpful content. So this is a sort of lead on to this morning's Young Emerging Researcher workshop, where we really talked about how to convey research to the lay community and the affected community. So each of these prizes are worth $250 US. And first off, we have Addie Mondell from Ashram, who will present the Ashram Community Engagement Award. And again, hopefully we play.
Hi there, my name is Addie Mundell and I'm the Acting Hepatitis B Program Manager at Ashram. Today I'm on Gadigal land of the Eora Nation, and I'd like to pay my respects to the elders past and present and extend that respect to any Aboriginal and Torres Strait Islander peoples watching this recording. I'm delighted to present the Community Engagement Award on behalf of the Hepatitis B program at Ashram. This award celebrates individuals and projects that strengthen connections between communities, health professionals and researchers to create real impact in the hepatitis B space. It shines a light on leadership that drives awareness, reduces stigma and ensures lived experience is front and centre in shaping change. At Ashram, we are committed to supporting the health workforce and the communities affected by hepatitis B. Within our program, we focus on building capacity, improving access and advocating for stronger prevention and care. I'm thrilled to announce the recipient of this award, Dr. Samuel Ogulande, for their research and important campaign on increasing hepatitis B vaccination of medical students in Nigeria. Dr. Samuel's work exemplifies Ashram's values by highlighting the risk factors faced by medical students and identifying gaps in knowledge, vaccination and protection. Your work has contributed both powerful research and meaningful advocacy. This is exactly the kind of leadership that moves the hepatitis B response forward. It's a privilege to recognise your achievement today. Congratulations.
And I'd like to add that project was supported by the Hepatitis B Foundation. So for our next award, we have the ICE-HBV Community Engagement Award. This is the Australian Centre for Hepatitis Virology, which is the peak body of biomedical scientists throughout Australia with the common interest of promoting and disseminating research into all aspects of the hepatitis B and related viruses. Full disclosure, I happen to be the current serving president of ICE-HBV. So I'd like to congratulate this year's winner, Laura McCulloch. Laura is a postdoc in Peter Revel and Margaret Littlejohn's lab at the Peter Doherty Institute for Infection and Immunity in Melbourne, Australia. Her postdoc is focusing on developing a potential new treatment for hepatitis B using CRISPR-Cas13b, and this is what she talked about in her post. So congratulations, Laura. We've got a certificate for you, but in terms of time, we'll hand them out all at the end. Thank you. But thank you, Laura. Great. Next, we have the International Hep B Meeting Award. I'm up here, so I might as well present, that's okay. So we have the winner of that being Holly Walden. So Holly is a PhD graduate student in the lab of Dr. John Tavis at the St. Louis University School of Medicine. Her research, which she shared with the community, is about investigating the biological and pharmacological characteristics of a novel class of HBV RNase H inhibitors. So thanks, Holly, and congratulations. And for our next award, we have, I'll represent the Store Liver Centre at the Westmead Institute for Medical Research, where I work. So the Store Liver Centre is a world-leading research centre in Western Sydney, studying all aspects of hepatitis and related viruses, as well as all different liver diseases. And this year's winner is Jochen Wettengel, who is a junior group leader at the Institute of Virology at TUM in Munich. His research focuses on the very first steps of hepatitis B infection with the essential question, why can the virus enter liver cells and not other cells? So he used simple explanations and vivid metaphors about how cells work and how the virus operates. Using this, he illustrated a major finding, how HBV attaches to ApoE and guides the virus into the cells. So well done, Jochen. And for our final award, we've got the GISA Award. The GISA is the Gastroenterological Society of Australia, the peak membership organisation for Australian healthcare professionals and researchers working in gastroenterology and hepatology. So I will be reading out prepared remarks from Jess Howe, who is the head of the liver faculty. So she is delighted to present the GISA HBV Research Award to Carla Coffin and the team, with Adam Gehring as PI, Thomas Mikulak, Jordan Feld, and Scott Fung, for their project entitled Pathfinder, which is a way to carefully characterize the immune responses in the blood and liver in people who have spontaneously cleared hepatitis B. And they'll be using cutting-edge lab techniques and AI to discover how the immune system achieves cure in these people. So well done, Carla. So that ends the fourth research showcase of hepatitisbcommunity.org. I'd like to thank and congratulate again all of our winners, and really thank everyone who participated and entered into these discussions. You're all essential in making this community work and make sure we're on track to make Hep B history. Thank you.
So to close out this first session, I wanted to invite Dr. Maura Dandry, who is the current chair of ICE-HBV and a professor at the University Medical Center Hamburg.
So thank you very much, Cherry, for the kind introduction. Now I don't want to steal the last 5 minutes that you have before the exciting meeting is really starting, but please let me at least thank you briefly all the participants online and in presence. As a chair of the International Coalition to Eliminate Hepatitis B, we are working very close together with the Hepatitis B Foundation, so many thanks to all the participants, to the clinician for joining today, in particular for the patient, thanks to the patients for sharing your thoughts, your experiences with us. This is, I think, it is very important. We all know, as a science coalition built up from by the scientific community that to reach a cure for hepatitis B and D, it's quite challenges. We also are aware that somehow the research in this field has been largely underfunded, and how difficult and how important are this type of meeting and to go to promote more advocacy. So we share a common aim and vision and goal with the Hepatitis B Foundation, and are sure that we need a coordinated action between academic foundations, governments, and industry and the patients community. Actually, it's really essential to increase awareness of these diseases. So we want to broaden accessibility of treatments also and promote the development of curative therapy. So therefore, I would like particularly to thank the HBV Foundation and Cherry for leading actually the organization of the yearly community HBV Forum, and of course, and to promote for the great really job in promoting advocacy, awareness, informing our patients. So thank you all for joining and have fun. I think they're a very exciting day awaiting to exchange new data and enjoy research and the meeting in Berlin. Thank you very much.